Hello everyone. So today's topic is development of GIT 2, that is development of midgut and accessory glands. So development of midgut, we will start from where we have ended the development of GIT 1, that is till the first part of the duodenum where the opening of the common bile duct is there, that is anterior intestinal portal. So this we have already seen. There is a midgut, U-shaped primary intestinal loop which is suspended from the posterior abdominal wall by a short mesentery that is known as mesoduodenum, and here the arterial supply of midgut is superior mesenteric artery, and at the apex of the mesentery the midgut is communicating with the yolk sac through vitelline duct or vitellointestinal duct. Now if we see here, this is the midgut, and because of this superior mesenteric artery it is divided into pre-arterial segment which lies proximal or cranial and post-arterial segment which lies distal or caudal. Then there is a cecal bud which is present on the post-arterial segment. It is a small conical diverticulum at the anti-mesenteric border, because this is the mesenteric border where the mesentery is attached. So this is anti-mesenteric border of the post-arterial segment of midgut. So here this cecal bud, in future it is going to form the cecum and appendix. Now the derivative of pre-arterial and post-arterial segment. Pre-arterial segment of midgut loop gives distal half of the duodenum, that is extending from the opening of the common bile duct in the second part of the duodenum, then the third part of the duodenum, fourth part of the duodenum, then jejunum, and then ileum, except its terminal part that is present here. Post-arterial segment of the midgut give the terminal part of ileum, then it forms cecum, appendix, ascending colon, and right 2/3 of transverse colon, because here at the junction of right 2/3 and left 1/3 of transverse colon there is posterior intestinal portal which is junction between midgut and hindgut. So during the third week of intrauterine life there is rapid growth of midgut loop and enlargement of liver at the same time. Because of this, abdominal cavity is temporarily becomes too small to accommodate all the loops of the midgut. So during 6th week of intrauterine life, loop of midgut herniate through the umbilical opening. They enter the extraembryonic coelom in the proximal part of umbilical cord. So here these loops are coming out through the abdominal cavity, and this is a normal phenomena because abdominal cavity is temporarily too small to accommodate all the loops of the midgut, and this is known as physiological umbilical hernia. Now rotation of the midgut. So rotation of the midgut results in the return of the herniated loop back into the abdominal cavity, and the rotation begins in 3rd month of the intrauterine life. And because of the rotation of the midgut there is establishment of definitive relationship of various parts of the intestine, whether it is a small intestine, whether it is ascending colon, descending colon, ascending colon, and the right 2/3 of transverse colon, and then there is descending colon. Now before rotation, if you see here, before rotation from above downwards in sagittal plane, pre-arterial segment of midgut is uppermost, then there is superior mesenteric artery, and then there is post-arterial segment. So we can see here the yellow color in this schematic diagram. The yellow color is the lumen of pre-arterial segment, this red color is lumen of the superior mesenteric artery, and green color is the lumen of post-arterial segment of midgut loop. Now because of rotation of midgut there is the position change in all these three structure. So the total rotation is of 270 degree, first 90-degree rotation occurs within the umbilicus, that is outside the abdominal cavity, and remaining 180-degree occurs within the abdominal cavity. So you remember this, again I am repeating, pre-arterial segment is uppermost, then there is superior mesenteric artery, then there is post-arterial segment in sagittal plane from above downwards. Now, what are the different steps in the rotation of the midgut? So first, pre-arterial segment of the midgut loop undergoes 90-degree anti-clockwise rotation. So, and that is happening outside the abdominal cavity within the umbilical cord. So here you see the first 90-degree anti-clockwise rotation. The pre-arterial segment, which was the uppermost, now it will come on the right side. Superior mesenteric artery will stay as such, and post-arterial segment will go on the left side. So this is the first 90-degree rotation. So pre-arterial segment coming to the right, post-arterial segment going to the left. Pre-arterial segment of the midgut loop now will elongate extensively, and it will form the coils of jejunum and ileum, and they will be lying on the right side of the superior mesenteric artery but outside the abdominal cavity. Okay, so one thing you should remember, first there is a rotation is happening, first 90-degree rotation, and now along with that elongation of the pre-arterial segment is also happening. Now you can see here the coils of jejunum and ileum will return to the abdominal cavity. Now the second 90-degree anti-clockwise rotation will happen. Now we already have seen in the previous slide that the pre-arterial segment was on the right side. Now because of another 90-degree anti-clockwise rotation, the pre-arterial segment came below the superior mesenteric artery from the right side, and the post-arterial segment went above the superior mesenteric artery from the left side. So now the coils of jejunum and ileum, which are derived from the pre-arterial segment, they are passing behind and beneath the superior mesenteric artery. So duodenum will go behind the superior mesenteric artery. Also now what will happen, the post-arterial segment will return to the abdominal cavity. It will undergo the third 90-degree anti-clockwise rotation. So you can see here, and we will not forget that there is extensive lengthening of the loops also happening. Now cecum and appendix that develop from the cecal bud now come on the right side. You can see here the cecal bud is forming the cecum and appendix. They are coming on the right side. Okay, from above now they are coming on the right side. Ascending colon is not visible, and it is formed when the cecum is descending into right iliac fossa, when it is coming down into the right iliac fossa. Now transverse and descending colon also gets defined, and they lie anterior to the superior mesenteric artery. Here you can see the remaining of the transverse colon and the descending colon, they are lying anterior to the superior mesenteric artery. So that is the midgut rotation. Now development of cecum and appendix. So there is a conical dilatation that appears in the post-arterial segment of the midgut loop near its apex, that is known as cecal bud. And the cecal bud has two parts, proximal and distal part. The proximal part is growing rapidly and it is going to form the cecum, and distal part is this one that is remaining narrow and it is going to form the appendix. Now the changes in the shape of cecum and appendix will happen. So here the growth of cecum after the birth will lead to change in its shape and in the change in the position of the attachment of appendix. So you can see here growth is not there, and so this is the proximal part and this is the distal part of cecal bud. Now there is growth is happening. So at birth cecum is conical in shape. You can see here it is conical in shape, and vermiform appendix is present at its apex. Now cecal will grow and it will result in formation of two saccule. You can see there are two saccule formed, but at the same time what will happen, among these two saccule, the right saccule will grow more faster than the left saccule, and the apex of this cecum, that is where the appendix is going to form and where the attachment of appendix with cecum is there, it is more pushed towards the left near the ileocecal junction. So now in adult, the base of appendix is attached to the posteromedial wall of the cecum near the ileocecal junction. Reason, as I have already told you, the right saccule of the cecum is increasing in size more than the left saccule of the cecum. So based on the shape of the cecum and the position of the appendix or attachment of the appendix, cecum can be conical, which is also known as fetal type or type 1 type 1. Then there is infantile type, where there is equal size of right and left saccule of cecum is there, that is known as infantile type, also known as quadrate type because of its quadrangular shape. Third one is normal type, which is present in 80 to 90% of adult. Here you can see the right saccule is much bigger, and you can see this, the appendix is attached on the posteromedial wall and it is more closer to the ileocecal junction. And the last one is exaggerated type, which is type 4 of the cecum, where there is much more growth of the right saccule of the cecum. Now congenital anomalies. So first one is exomphalos or amphalocele. So it results from failure of the coils of small intestine to return into abdominal cavity from their physiological herniation during 6th to 10th week of the intrauterine life. As I have already mentioned, during the midgut rotation, before that there is physiological hernia. So if that physiological herniation is not returning back, that will lead to the exomphalos or amphalocele. It can be associated with cardiac or neural tube defect. It can be presented as a rounded mass of protruding from umbilicus, and mass contains coils of a small intestine and covered by transparent amniotic membrane. Okay, so that is exomphalocele exomphalos or amphalocele. Remember, it is covered by here the amniotic membrane. Okay, so the reason being is it is because of failure of return of the loop of the small intestine after the physiological herniation. Second one is congenital umbilical hernia, the herniation of abdominal viscera through the weak umbilical opening, which is actually poorly closed. So remember here what is the difference between these two conditions, congenital umbilical hernia and amphalocele. In amphalocele, the physiological herniated loop are not returning back. In case of congenital umbilical hernia, the loop have returned back, there was normal development, and then through weak umbilical opening, the abdominal viscera has been herniated. So clinically it is presented as protrusion in linea alba, and the contents are covered with peritoneum, subcutaneous tissue and skin, and hernia can be reduced by pushing intestine back into abdominal cavity through umbilical opening. Size of hernia increase during the crying, coughing and straining because of increased intra-abdominal pressure, and congenital umbilical hernia gets reduced on its own within 2 to 3 years of life, and child is subjected to surgery only when the hernia stay after the age of 2 to 3 years. Third one is gastroschisis. Now what is gastroschisis? It is because of linear defect in anterior abdominal wall through which abdominal content is herniating out. The reason is here this defect is because of lateral fold of embryo are failed to fuse with each other during around the connecting stalk when the lateral folding is happening. Okay, so lateral fold are not fusing, leaving an opening in the midline, and usually this is lying lateral to the umbilicals and more common on the right side. Now if you want to See here the difference between the three conditions. First one is omphalocele or exomphalose, then there is congenital umbilical hernia, then there is gastroschisis. Omphalocele, as I have already explained you, it is herniation of the bowel loop through umbilical opening, that is at the time of physiological herniation, and that is failed to return to abdominal cavity later when it should have been returned. It is covered by peritoneum, Wharton jelly and amnion, and it has genetic basis, that is why it is associated with cardiac defect or neural tube defect, and prognosis is bad in omphalocele. Second one is congenital umbilical hernia. It is herniation of bowel loop through weak umbilical opening. Here umbilical fails to close properly, and here the contents are covered by peritoneum, subcutaneous tissue and skin. There is no genetic basis and prognosis is usually good. Third one is gastroschisis, herniation of abdominal content through linear defect in anterior abdominal wall. It is lying lateral to the umbilicus, usually on the right side. It is produced due to failure of fusion of lateral fold of embryo each other around the connecting stalk. Prognosis in gastroschisis is much bad. It is worst. Okay. Now, anomalies of vitellointestinal duct. We know already there is vitellointestinal duct which is connecting apex of the midgut loop to the yolk sac here. Normally it disappears completely. Failure to disappear it completely or in parts will produce different type of anomalies of vitellointestinal duct. So these can be an anomaly. First one is Meckel's diverticulum. It is a small persistent part of vitellointestinal duct which is close to the midgut, that is ileum, and it may be connected to the umbilicus by a fibrous cord. Here there can be a fibrous cord, and it is obliterated, and it is a small diverticulum arising from the anti-mesenteric border of ileum. Remember rule of 2, it is about 2 inches in length. It is 2 feet proximal to the ileocecal junction, and it occurs in 2% of people. It may contain gastric mucosa or pancreatic tissue. There might be ulceration, bleeding or even perforation, and it may undergo inflammation, symptom of which may mimic to that of appendicitis. So that is Meckel's diverticulum. Second one is umbilical sinus. So here the part of vitellointestinal duct close to umbilicus persists. That is, here it is failing to fuse. So it is blind sinus which is communicating outside, but it is not communicating with midgut. So this is known as umbilical sinus. Third one is umbilical fistula or vitelline fistula. Here there is communication of the midgut outside through the persistent vitellointestinal duct outside through the umbilical opening, and here the vitellointestinal duct is failed to obliterate. Okay, so because of this fistula, the ileum will be communicating outside at the umbilicus, and ileal content may discharge through the umbilicus. So this is umbilical fistula or vitelline fistula. Third one is vitelline cyst. Here you can see small middle part of vitellointestinal duct persists. Proximally it is obliterated, distally it is obliterated, so it will present as a cystic swelling. Now anomalies due to error of rotation of midgut. First one is non-rotation. Here there is no rotation at all. So the caudal or post-arterial segment returned first in abdominal cavity, and the large intestine occupies left side of the abdominal cavity. Small intestine derived from the pre-arterial segment is returning later, and it occupies the right side of the abdominal cavity. So you can see here the right side is pre-arterial segment, left side is post-arterial segment. Partial rotation. Here the first 180 degree of rotation takes place normally, but the last 90 degree of rotation does not take place. As a result, cecum and appendix, instead of being on the right side of the abdominal cavity, they are located just below the pylorus of the stomach. And the third one is reversed rotation. Here midgut loop rotates clockwise instead of anti-clockwise. So transverse colon passes behind the duodenum and it is lying behind the superior mesenteric artery. Then there is subhepatic cecum and appendix. This is because of undescended cecum and appendix. If the ascending colon does not form or remains too short, so because of this, cecum does not descend and remain permanently below the liver, and because of inflammation of appendix, which is known as appendicitis, it will cause tenderness in the right hypochondrium, and that may lead to mistake diagnosis of cholecystitis. Okay, because here it is subhepatic cecum and appendix. Sometimes the cecum may descend only partially in lumbar region or may descend too much to reach in the pelvic region. So these all are anomalies of the position of the cecum and appendix, which might be related with the improper midgut rotation. Fixation of midgut derivative. So the midgut loop has a dorsal mesentery which is known as mesentery proper, which is attached to the posterior abdominal wall in the midline. Here you can see the mesentery. As coil of small intestine return to the abdominal cavity, line of attachment of mesentery shift and lies obliquely from duodenojejunal flexure to ileocecal junction. So this is the root of the attachment of the mesentery. So the caudal part of the loop or the post-arterial segment of the loop moves to the right side of abdominal cavity. Dorsal mesentery twists around the superior mesenteric artery. Ascending colon has a short mesentery at first, but as ascending colon elongating its mesentery, it fuses with the parietal peritoneum and ascending colon becomes retroperitoneal by zygosis. Transverse colon retain its mesentery and which run transversely from right to left on the posterior abdominal wall. So mesentery of transverse colon is known as transverse mesocolon. Now coming to the development of accessory glands, first of among them is liver. So when you see here the midgut, okay, the junction of foregut and midgut, so on the ventral aspect of distal part of the foregut, where its junction with the midgut is there one endodermal bud arise which is known as hepatic bud. Now this hepatic bud grows into ventral mesogastrium, okay, and it goes into the septum transversum, and this hepatic bud is going to form the liver. Now when you can see here this endodermal bud which is known as hepatic bud, it has two parts, the large cranial part and a smaller caudal part. The large cranial part forms the pars hepatica and a smaller cranial caudal part forms the pars cystica. The pars hepatica going to form the liver and pars cystica is going to form the gallbladder and cystic bud. Now you can see here again the pars hepatica. The pars hepatica has two parts, the right and left. The right part is going to form the right lobe, the left part is going to form the left lobe. The cells which are arising from the pars hepatica, they are going to form the hepatic cords, and there are vitelline and umbilical veins present here which are present within the septum transversum. They are broken and they are going to form the liver sinusoids. So now histogenesis of liver. Hepatic bud is going to form the liver parenchyma and bile canaliculi and bile ductules. The vitelline and umbilical veins which are present within the septum transversum, they are going to break and they are going to form the liver sinusoid. And septum transversum, which is mesodermal in origin, it going to form the connective tissue stroma of the liver, including the Gleason capsule, peritoneal covering of the liver, Kupffer cells, hemopoietic cells and blood vessels of the liver. Congenital anomalies of the liver. First one is Riddle's lobe. It is tongue-like extension of from the right lobe of the liver. It develops as an extension of normal hepatic tissue from the inferior margin of the right lobe of the liver. Then there is polycystic disease of the liver. Here biliary tree within the liver normally connect them with the extrahepatic bile tissue, bile duct. The failure of union of These duct may cause formation of cyst within the liver. Usually they are associated with cystic disease of kidney and pancreas. Intrahepatic biliary atresia. Intrahepatic biliary atresia cannot be subjected to surgical correction. As a result, there are only two options are there, either to go for liver transplant or let the child die. Then there is Caroli disease. It is congenital dilatation of intrahepatic biliary tree, may lead to formation of sepsis, stone and even carcinoma. Other anomalies can be rudimentary liver, absence of quadrant lobe, presence of accessory liver tissue in falciform ligament. Development of gallbladder and extrahepatic biliary tissue. The gallbladder, as I have already told you, it is developing from pars cystica. Pars cystica is arising from the hepatic bud. So the part of hepatic bud proximal to the pars cystica forms the common bile duct. So here this part of the hepatic bud is going to form the common bile duct, and pars cystica is going to form the gallbladder and cystic duct, and the pars hepatica is going to form the liver. After growth and rotation of duodenum, opening of common bile duct is carried to dorsomedial aspect of duodenum along with ventral pancreatic bud. Initially, extrahepatic biliary apparatus occluded with epithelial cells. Later, they are recanalized by way of vacuolation, resulting from degeneration of cells. Congenital anomalies are related to gallbladder and cystic duct. So, there can be agenesis of gallbladder. There is no gallbladder here. If pars cystica from hepatic bud fails to develop, gallbladder and cystic bud will not develop. Then absence of cystic bud. So here entire growth of cells of hepatic duct from gallbladder only, entire growth of cells of hepatic bud are going to form the gallbladder. See here, there is no cystic duct. So there is sessile gallbladder and it directly drains into common bile duct. So sometimes surgeon may fail to recognize this condition while performing cholecystectomy, and they may cause serious damage to common bile duct. Then other anomalies, which are anomalies of the gallbladder, shape of the gallbladder. First one is Phrygian cap, when fundus of gallbladder fold on itself to form a cap-like structure, that is known as Phrygian cap. There is Hartmann pouch. Pouch is formed when posterior medial wall of neck or infundibulum of gallbladder is projecting downward. So this is Hartmann pouch. Pouch may be adherent to cystic duct or even to the CBD. Gallstone is usually seen lodged in this pouch. There can be septed gallbladder and double gallbladder. Sometimes gallbladder is partially or completely subdivided by a septum, or sometimes there is partial or complete duplication of gallbladder. Then anomalies of position of gallbladder. Gallbladder may lie transversely on inferior surface of right or left lobe of liver. Sometimes there can be intrahepatic gallbladder when the gallbladder is present within the substance of the liver. Sometimes there can be floating gallbladder. Gallbladder is surrounded by peritoneum and attached by a fold of mesentery. So these all are anomalies. Okay, so you can see here, this is the Hartmann pouch. This is the Phrygian cap, this is septed gallbladder, this is a double gallbladder, this is intrahepatic gallbladder. Here there is absence of entire hepatic duct system. Here there is atresia of common bile duct. Here there is accessory bile duct and there is choledochal cyst. Anomalies of extrahepatic bile duct. There can be atresia of duct. So atresia of bile duct, or there can be entire hepatic biliary duct system can be absent. There can be absence of common hepatic duct. There can be absence of hepatic duct. Atresia of the bile duct manifests as persistent progressive jaundice of newborn, and it can be associated with absence of ampulla of water. There can be accessory duct, there can be choledochal cyst, there can be Moynihan hump. The small accessory bile duct may open directly from liver into the gallbladder in case of accessory duct. You can see here, in case of choledochal cyst, it is developing due to an area of weakness in wall of bile duct. It may contain 2 liters of bile and may compress the bile duct to produce an obstructive jaundice. Then there is Meinhard hump. Here hepatic artery lies in front of common bile duct forming a caterpillar-like loop. Now development of pancreas. There is one dorsal pancreatic bud. It is arising from the dorsal wall of the foregut a short distance above the ventral bud and grows between the two layers of dorsal mesentery of duodenum. So here is dorsal pancreatic bud. And then there is ventral pancreatic bud. It arises from the ventral wall of the foregut in common or close to the hepatic bud and between the two layers of ventral mesentery. So there are two bud. One is dorsal pancreatic bud, one is ventral pancreatic bud. Now due to rotation of the duodenum to the right and becoming C-shaped, ventral pancreatic bud on right side and dorsal pancreatic bud is on the left of the duodenum. You can see here the dorsal pancreatic bud and ventral pancreatic bud. So with the rapid growth of right duodenal wall, ventral pancreatic bud shift from right to So ventral pancreatic bud, as I have shown you here, there is ventral pancreatic bud, there is dorsal pancreatic bud. Now these, because of rapid growth of right duodenal wall, ventral pancreatic bud shift from the right to left and lies below dorsal pancreatic bud. The dorsal and ventral pancreatic bud grows and fuse with each other to form the pancreas. So you can see here the dorsal pancreatic bud forms the upper part of the head, neck, body and tail of pancreas, and ventral pancreatic bud forms the lower part of the head and uncinate process of pancreas. The development of ducts of pancreas. Initially, two parts of the pancreas derived from two pancreatic bud have separate duct called dorsal and ventral pancreatic duct that open separately into duodenum. Opening of the dorsal pancreatic bud is about 2 cm proximal to the opening of ventral pancreatic duct. The ventral pancreatic duct opens in common with the bile duct derived from the hepatic bud. So you can see here within the dorsal pancreatic bud there is one duct. Within the ventral pancreatic bud there is ventral pancreatic duct. Ventral pancreatic duct open in common with the bile duct derived from the hepatic bud. So you can see here the dorsal pancreatic duct is directly opening, but the ventral pancreatic duct is opening along with the common bile duct. Now there is communication between the dorsal and ventral pancreatic duct. So you can see here communication is between the dorsal and the ventral pancreatic duct. Development of duct, here you can see here the main pancreatic duct, which is the duct of Versung, it is developing here from the dorsal pancreatic duct dorsal to the communication with the ventral pancreatic duct. So this is, and then here ventral pancreatic duct. So the main pancreatic duct or duct of Versung developed from dorsal pancreatic duct distal to anastomosis between two ducts, anastomosis between the two duct and the ventral pancreatic duct proximal to the anastomosis. The main pancreatic duct opening into the duodenum with the bile duct as major duodenal papilla. Okay, the proximal part of the dorsal pancreatic duct persists as accessory pancreatic duct, which is known as a duct of Santorni, that opens in duodenum at minor duodenal papilla located about 2 cm proximal to major duodenal papilla. Now histogenesis of pancreas. So parenchyma of pancreas is formed from the endoderm of pancreatic bud. Pancreatic bud branch out in surrounding mesoderm and form various ducts such as intralobular, interlobular and main duct. Pancreatic acini began to develop from cell cluster around terminal part of duct. Islet of Langerhans develop from group of cells that separate from duct system. Capsule covering the gland, septa and other connective tissue element of pancreas with blood vessels develop from surrounding mesoderm. The beta cells of islet of Langerhans start secreting insulin by 10th week of intrauterine life, and alpha cell which secrete somatostatin develop prior to the insulin secreting beta cells. Congenital anomalies of pancreas. There is annular pancreas. So pancreatic tissue surrounding second part of duodenum causing its obstruction here. Bifid ventral pancreatic bud fail to fuse to form a single mass. You can see here there is ventral pancreatic bud and there is dorsal pancreatic bud. This is not going and fusing with the dorsal pancreatic bud, so it is completely surrounding the second part of the duodenum. This is known as annular pancreas. It may cause duodenal obstruction. The two lobe, right and left lobe of the ventral pancreatic bud grows and migrate in opposite direction around the second part of duodenum, and they form collar of pancreatic tissue before it fuses with the dorsal pancreatic bud. Clinical feature can be vomiting, which may start few hours after birth. Radiograph appearance will be double bubble appearance, and it will be associated with duodenal stenosis. Surgical procedure consists of duodenojejunectomy and not cutting of pancreatic collar. There can be divided pancreas, occurs when dorsal and ventral pancreatic bud fail to fuse with each other. Two parts of the pancreas derived from two buds remain separate from each other. Accessory or ectopic pancreatic tissue. Here heterotropic small masses and nodules of pancreatic tissue may be formed at following sites, either in wall of duodenum, Meckel's diverticulum, gallbladder, lower end of esophagus or wall of stomach. Then there can be inversion of pancreatic duct. So the main pancreatic duct formed by duct of dorsal pancreatic bud and open on minor duodenal papilla, and it drain most of the pancreatic tissue. The duct of the ventral pancreatic bud poorly developed and it opens on the major duodenal papilla. And the last one is development of spleen. Spleen is mesodermal in origin. It is a lymphoid organ. It is developing in the dorsal mesogastrium in close relation to the stomach. Mesenchymal cells lying between two layers of dorsal mesogastrium, they condense to form several small mesenchymal mass. Lobule of splenic tissue and spleneculi which fuse to form a single mesenchymal mass and project from undercover of left layer of mesogastrium. Development of spleen in mesogastrium divide the mesogastrium into two parts. The gastrosplenic ligament, which is the part of dorsal mesogastrium extending between the hilum of spleen and greater curvature of stomach here, and the splenorenal or lenorenal ligament, which is part of dorsal mesogastrium that is extending between the spleen and left kidney on posterior abdominal wall. Presence of splenic notches on the anterior or superior border of adult spleen indicate lobulated origin of spleen. So the histogenesis of spleen, all elements of the spleen are derived from mesoderm. Mesoderm cells form capsule, septa and connective tissue network including reticular fibers. Primordium of splenic tissue form branching cords and isolated free cells. Some of the free cells form lymphoblast while other differentiate into hemopoietic cells. Process of blood formation in spleen begins in early embryonic life and continue during fetal life, but it stops after birth. And production of lymphocyte, however, continue in the postnatal period. So congenital anomaly, there can be accessory spleen, which is known as spleneculi. Accessory nodules of splenic tissue may be found at many sites such as hilum of spleen, gastrosplenic ligament, lenorenal ligament, in the tail of pancreas, along the splenic artery, greater omentum, or sometime even in the left spermatic cord. Clinical importance: may undergo hypertrophy after splenectomy, may be responsible for symptom of disease for which splenectomy was done. There can be lobulated spleen, persistent of fetal spleen, which is formed due to fusion of several small lobules of splenic tissue. These are the references. Thank you.